Welcome to Observations, an open conversation about women's health. This is a space where physicians, patients, and other experts can sit down and have honest, evidence-based dialogue that cuts through the media bias and brings clarity back to maternal care and how we can care for both patients, mother and preborn child. With each episode, we will have real stories, real science, but also real questions about women's health today. From clinical insights to lived experiences, to aligned perspectives, and yes, also respectful disagreements. This is our goal, to bridge the gap between physician and patient, to empower informed decision-making, and bring back and elevate compassionate, fact-driven care. Now, a quick note before we dive in. Not every guest on the podcast is going to represent the views or positions of Applog, but we believe that having open and honest conversations are going to make us better. So, grab your coffee, settle in, and let's get into today's observation.
I'm your host for today, Dr. Christina Francis, and welcome back to Observations. We have a fun and slightly different kind of episode for you today that we haven't done for a while. While I'm technically your host, I'm going to actually be handing things over to my good friend and fellow pro-life advocate, Monica Snyder, who will actually be interviewing me about some pro-life hot topics from a medical perspective. Today, we're going to be diving into how pro-abortion media and also abortion advocates often conflate things like miscarriage and ectopic pregnancy treatment with abortion in an effort to influence public opinion, especially when it comes to pro-life laws, and also just, I think, some misunderstandings that a lot of patients have about these issues. We've seen this play out recently with a case that was reported out of Arkansas, and also with Representative Cammack, whose ectopic pregnancy treatment was delayed back in 2024 after doctors were influenced by misleading claims that they could potentially face jail time for treating ectopic pregnancy, even though Florida law, like every other law in the country, clearly allows treatment in these cases. So I can't think of a better person to explore these topics with. Monica spends much of her time and energy identifying and pushing back against misinformation in this space. Monica is a pro-life atheist and the executive director of Secular Pro-Life, a single-issue organization focused on advancing secular arguments against abortion and also building coalitions. She was actually one of our most favorite speakers at our conference this year because of her expertise in this area of how to have these difficult conversations. Monica holds a BS in chemical biology from UC Berkeley and an MS in forensic science from UC Davis, and has spent much of her adult life in secular urban communities surrounded by pro-choice peers. She's especially passionate about fostering friendships across ideological lines and helping pro-life advocates have meaningful and productive conversations with those who disagree. Monica, thanks so much for joining us on Observations.
Thanks for having me.
It's so great to have you, and I'm going to turn it over to you now.
Great. So Christina and I have a lot of different topics we could cover, but we decided today to focus on miscarriage and ectopic pregnancy, kind of putting those together in terms of medically necessary care that can get tripped up by people's understandings or misunderstandings about anti-abortion laws. And we're going to start with stories we hear from people about what I think is probably normal medical care that they're worried is abnormal. So this will be different than when we talk about Emily Waldorf and Kat Cammack. I see stories online, not abortion activists, just normal private citizens talking about, especially either if they experienced an ectopic pregnancy or a missed miscarriage, which is when the child has died, but the woman has not passed all or any of the remains. And they'll go to their medical team and the team will suggest a course of action that requires a lot of waiting. And they will worry that they're in some sort of immediate emergency and they're not getting the treatment they need potentially because of these laws. So can you talk about what would be different possible normal courses of action if a patient comes to you with an ectopic pregnancy or a missed miscarriage? Like, what are some reasons that doctors may say, okay, we're going to try this and check back in a week.
Yeah, absolutely. I'm so glad that you asked if we could talk about this today because you're right. These can be very confusing for patients, and I wouldn't want patients to think that doctors are making decisions that aren't good for their health because of a potential law, or even just that it's abnormal care, like you said. So I'll take ectopic pregnancy first because sometimes that's a little bit more clear, but if a woman presents with, typically they would present maybe with some spotting, and we do an ultrasound to see is everything okay with her baby, and do some blood work. Sometimes we can't see an ectopic pregnancy immediately, even though it's there. And so, there are situations where maybe her HCG levels, which is that pregnancy hormone level, might be a little on the low side, under what we call the discriminatory zone of that. So there's a certain value of HCG where we know if there's a normal pregnancy in the uterus, we should be able to see it at that point once her HCG level hits a certain point. So if it's below that and we don't see anything on the ultrasound, we don't see an obvious ectopic pregnancy, or we don't see anything in the uterus, then it could be an ectopic, it could be a miscarriage, or it could be a normal intrauterine pregnancy. And so at that point, typically our recommended course of action would be, let's repeat your levels in 2 to 3 days. There's a certain rise in that level that we expect to see if the pregnancy is doing well, if it's where it should be. And then if it doesn't, then we might be a little bit more suspicious of something like an ectopic pregnancy. So that's very common. And I've had patients where they're stable, and we've done that 2 or 3 times actually. So, that would take the course of about a week or so to repeat that test 2 or 3 times, where we've had to do that before we could make a definitive diagnosis of an ectopic pregnancy. So that would be a case where that's that sort of wait and let's follow you. Now, this isn't go away, come back in a week, we're not going to do anything. I don't want people to mistake it for that. But where we're following those blood levels and then maybe repeating an ultrasound once that HCG level gets up to a certain point so that we can see, okay, where is the pregnancy at? So that would be very normal. Now, of course, if a patient presents with severe pain and bleeding and we do an ultrasound and we can definitely see an ectopic pregnancy, that's very different. That should not have delayed treatment. That should have immediate treatment to prevent uh, serious danger to the mom. So,
A follow-up question about that, though.
yeah,
Correct me if I'm misunderstanding, but the possible treatments for confirmed ectopic pregnancy can still range in how long they take to complete. The treatments can, right?
correct, correct. So there's sort of two broad treatment options for ectopic pregnancies. One would be surgery, and there's a couple different types of surgery that can be done. So that would be more immediate, of course. And the other would be using a medication called methotrexate. And there's certain conditions that qualify a woman to have methotrexate as an option, as a treatment option. But if she chooses to do methotrexate, then a dose, typically a single dose is given, although there's some clinical scenarios in which a second dose might be given. But that's not an immediate resolution of her ectopic pregnancy. So a dose of methotrexate is given, and then we actually do have to follow those HCG levels. Again, we expect them to decrease by a certain amount every so many days to know that the methotrexate treatment has been effective. But we also have to follow her very closely, because if the methotrexate doesn't work and that ectopic pregnancy continues to grow, then she still could be in a life-threatening situation where then she would need emergency surgery. So typically,
How
if a
common
woman,
is it to pick surgery versus methotrexate in confirmed ectopic pregnancy?
I would say in my patient population, I mean, I think every patient population is probably slightly different, but in my patient population, I would say about 75% of patients choose surgery, or they have to have surgery. They don't qualify for methotrexate. So surgery is definitely more common than methotrexate. But if she qualifies and she chooses methotrexate, that's actually about a 2 to 3 week process before we can
Mhm.
say, definitively, okay, the methotrexate worked and you don't need any further follow up at this point. So, as you said, that's a process that would take a little longer. That's not abnormal medical care. That's standard medical care if that's the option she chooses.
Okay, makes sense. So to recap, maybe in layman's terms, With ectopic pregnancy, first of all, there can be uncertainty in diagnosis, and you may need to look for more evidence before you proceed, and that could take days to over a week even. And second of all, even if there is a confirmed diagnosis, the patient may choose to go with a treatment that can itself take weeks. Are there situations where the doctor would recommend the weeks-long methotrexate version versus surgery, or is it just you want to give them the option because surgery is so invasive and permanent?
Yeah, I think the only patient that I might really try to steer towards methotrexate, if possible, over surgery would maybe be somebody who had had a lot of surgeries in the past, or a condition that we feared she might have a lot of adhesion, scar tissue within her pelt, making surgery really potentially dangerous for her.
Hmm.
Um, but on the flip side of that, the other thing is if you're going in to do surgery on a stable patient, you can take your time, with getting to the source or the ectopic pregnancy versus if you're doing an emergent surgery. So let's say she takes methotrexate, but it doesn't work, and then she ruptures her ectopic pregnancy, and then you're trying to get in very emergently, having to deal with all that scar tissue and get to the source of the bleeding. That's also not ideal.
Right.
It's tricky. This is where our clinical judgment comes in and what we call shared decision making, where we talk with the patient about risks and benefits of all the different options and make a decision together as to what we think is best together with the patient. So that's a tricky one. I can't recall a patient that I've had that I've really, recommended. I really think you should think about methotrexate as opposed to surgery. The other option I suppose would be maybe somebody who only has one fallopian tube left, who maybe has lost her other tube. And so, the surgery typically is going to involve taking that tube out. And so, in that person who maybe wants that woman who really wants future fertility, methotrexate may be a better option for her to at least still have her tube. Now she's going to have a kind of a scarred tube. And so it's going to set her up for a higher risk of future ectopic pregnancies as well. But I've had patients in that scenario that, really, really wanted the option of being able to become pregnant in the future. And so they chose methotrexate for that reason.
Have you had patients where you're dealing with pregnancy of unknown location and it wasn't a pregnancy they particularly were excited about in the first place? Because that might change what they are thinking they want to do in terms of waiting and seeing, right?
Yeah, no, it definitely can. And there's a lot out there about this, options and as you said, pregnancy of unknown location. So that's where maybe the first time she's seen, we're just not sure. Again, her HCG levels are a little low, the ultrasound isn't really definitive. In that situation, what I typically tell patients is one, I want to be confident when I'm doing a treatment or performing some kind of intervention like a surgery that I know exactly what it is that I'm treating. And so I actually think just from a medical standpoint, it makes sense to know what you're treating because the treatments for ectopic pregnancy are different than the treatments for like a miscarriage or even what might be done for an induced abortion in,
Right.
a woman who doesn't want her pregnancy. So I actually just think from a medical standpoint, it's better. Again, this is assuming that the patient is stable. If she's not stable, then we probably know what's going on, right? If she's got a belly full of blood, then we know she's got a ruptured ectopic pregnancy. So even if we didn't see that
Right.
definitively,
But we're talking about a patient, maybe it's her first prenatal appointment, because it's more likely to have unknown location earlier in the pregnancy anyway,
right?
right?
Exactly.
And so maybe it's her first prenatal appointment. Maybe this is surprising news in the first place. And then there's this level of uncertainty and she's trying to decide what's going on. That's what we're talking about. We're not talking about she's presenting to the ER with abdominal pain or something.
Exactly, exactly.
Yeah.
And again, obviously I as a pro-life physician would not do an induced abortion. So if I think that there is a living baby growing inside of her uterus, I'm not going to do something to interrupt that regardless of what the patient wants to do with her
Right.
pregnancy. But I also think just purely from a medical standpoint, I don't think you can have fully informed consent unless you actually know what's going on. And then that's how you can talk about risks and things like that. So I
This
don't
is interesting. Just to clarify for listeners, 'cause I don't think I said it earlier. What we're talking about is there are some physicians where if you have potentially an unwanted or unexpected pregnancy and it's unknown location and the patient doesn't want to wait to find out if it's ectopic or intrauterine, then sometimes the method is, what do they call it? It's diagnostic.
Right. Like a
What is it
diagnostic
called?
aspiration. So you can like,
Diagnostic aspiration,
you
which
can
is,
go in and clear out any
it's
contents of the
essentially a
uterus.
method of either induced abortion or sometimes miscarriage care where you're clearing out the uterus. It's just in this case, you don't actually know if there is an embryo in the uterus, and if there is, this method will
And
destroy that embryo.
yeah.
Um, and so there are physicians who do that, and it reminds me a little bit of when they market abortion pills as missed period pills, where they don't require you to actually confirm if you're pregnant or what's going on, just like a just in case abortion that they call something different. It seems that to me is a little bit similar,
Right.
just an
Absolutely.
observation. Anyway, go ahead.
Absolutely. No, no, you're exactly right. And again, it actually matters for a woman's future health to know what happened with this pregnancy. So we need to know, did she have an ectopic? Because then she's at higher risk in future pregnancies for ectopic pregnancy. Did she have a miscarriage? Because what if this is her fourth or fifth miscarriage? Well, there's certain conditions we need to be looking for then that don't just impact her in pregnancy, but impact her outside of pregnancy as well, like blood clotting disorders, things like that. Or was this a perfectly healthy, viable pregnancy that was just very early? We couldn't see it yet on ultrasound. That makes an impact on her health. So that's even another reason why I think it's really actually irresponsible, regardless of somebody's position on abortion, to intervene when you don't actually know what's happening with the pregnancy.
Generally in medicine, it's good to have full and correct information if you can. So
Yes.
low bar.
If you are a good doctor, yes, that would be good. So,
Okay, so that's ectopic
that's
pregnancy then.
ectopic pregnancy. That's
And
right.
those are some reasons why you may find in normal pregnancy care delays between realizing there may be a problem and fully resolving it in normal medical care as a standard response. Now, talk to me about missed miscarriage, which again, I'll say for listeners is when the embryo of the child has died, but not passed out of the mom's body. Why would there be situations where there's a first of all, same idea. How do you diagnose it with certainty? And then even after certain diagnosis, why might there then be a delay between certain diagnosis and resolving with treatment?
Sure. So, again, great questions. Let's start with the first. How do we make the diagnosis? So it kind of depends on how far along in her pregnancy a woman is when she's seen, and has she had a previous ultrasound that showed that she had a living intrauterine pregnancy. If she had a previous ultrasound, so let's say she came in at 6 weeks and just happened to get an ultrasound and the baby looked fine. And then she comes back at 8 or 9 weeks, and now we look with ultrasound and there's no heartbeat. At that point, we can say with that single ultrasound, you've had a miscarriage because we previously had a heartbeat. Now there's no longer a heartbeat. The baby has passed away. So we can definitively.
Clearly, the heartbeat was detectable at some point.
Exactly.
Right.
So you saw it before. Now you're not seeing it. Okay. So we know we had a heartbeat before. So that's one way we can make a definitive diagnosis. Another way would be if she has very certain dates, so she's confident of her last menstrual period, and she comes in and she gets an ultrasound at 8, 9, 10 weeks, somewhere in that range, and we see the baby in the uterus, but there is no heartbeat whatsoever. At that stage of pregnancy, we definitely should be seeing a heartbeat on ultrasound. So I would say that you can make a definitive diagnosis at that point based on a single ultrasound. Now, that being said, I have definitely had patients come in who, we'll talk about a situation where maybe baby wasn't measuring that big in a minute, but I've definitely had patients in that situation where I, as the doctor, felt confident looking at the ultrasound. This baby's big enough. We definitely should see a heartbeat. But this is awful news for any woman, any family to receive. And oftentimes they just need time to process this information, or they really want to be sure that this is in fact what's going on. And so in that case, I have offered, and I think it is perfectly reasonable to offer to that patient, why don't you come back in a few more days? We'll do another ultrasound just to be sure. And then we can, discuss options from there. So that's a situation in which, I as a physician might feel pretty confident that this is what's going on, but recognizing that maybe the patient isn't quite ready. And I don't think that there's any harm whatsoever in that situation in waiting. So that's
Pause for a
maybe
second.
more a patient maybe wants that.
Elaborate a little bit more about not any harm in waiting, because I get the impression that there are a lot of people, including women who have gone through this situation, who think that as soon as they have a missed miscarriage, they are in danger and that they need to get that resolved immediately or something terrible could happen to them. So talk a little bit about how you would be comfortable, even when you're clinically sure it's a missed miscarriage, asking
Uh-huh.
them to come back in a few days.
Yeah, absolutely. So the important thing to point out is, especially if based on the woman's dates and how big the baby is measuring on ultrasound, if it looks like the baby passed away within, recent days or even within a week, week and a half, 2 weeks, something like that, there is no emergency. As long as her bleeding is minimal, as long as she's not showing any current signs of infection, there's no harm in waiting a few days if the patient needs that, or if, as we're going to talk about in a minute, we're not sure about the clinical diagnosis. Where we do get into trouble and where it's not okay to start waiting for a long time is if we think that the baby has been passed away for several weeks. So maybe she thinks that she's 16 weeks along based on her dates, but you do an ultrasound, the baby measures 9 weeks. In that case, most likely the has passed away several weeks ago. And at that point, that does set up an increased risk of infection. Again, it's not a surgical emergency or a medical emergency at that point, but I certainly wouldn't want to wait several days or, weeks before intervening.
Right.
Or if she's currently showing any signs of infection. So if she's got abnormal discharge, a fever, abdominal tenderness, anything like that, then that definitely needs to be have intervention done immediately. But in the vast majority of cases, that's not going to be the case. And so taking some time to allow the woman, her family to process this information before she then goes through the treatment for this is not dangerous to her. And in many cases, I'm not saying this is what every woman or every family wants, but in many cases I think helps with their grieving process because they're not having to make complex medical decisions in the
In
midst of
shock.
this like acute shock. Exactly.
And I
Exactly.
can just speak to that from the other side of the ultrasound, because my husband and I went through exactly this. And this was in California, where they're very friendly to abortion. And we went to our first prenatal appointment, and I think I was supposed to be around 8 or 9 weeks, and there was no heartbeat. And my OB told us, we can give you medication, we can schedule a DNC, we can wait and see. But every option she offered, she said, we can wait and talk about this in a week. There was no sense of medical urgency. Um, Obviously, there was a lot of emotional urgency. And at that time, I just assumed whatever she said was standard, which turns out it is, because there was no reason for it not to be. But it gave us time to talk about what we wanted to do. It gave us time to talk about how we wanted to handle things after. I've talked about this in other contexts about disposition of remains, things like that. And I agree with you that that's not necessarily what everyone would want, totally. Only to say that it's not medically abnormal care to offer that. Right.
Absolutely, absolutely. Yeah, I mean, the only thing I have not personally experienced a miscarriage, so the only thing I have to compare it to is when we found out that my dad had stage 4 pancreatic cancer, and then we're asked almost immediately to start making complex medical decisions for his care after that. And we needed time to process this information, before even me as a physician, before my
Of
mind could
course.
even
That just
work.
How do
So
people not know that? I
right,
don't
right,
understand
I
how
know.
that's even
So,
confusing. It's
so
annoying.
again, I think you and I are both acknowledging that there may be some women who don't want that time to process, but I think most actually do it and shouldn't be made to feel like they're endangering themselves if they take that time to process this information. Because the
So
other, oh, sorry, go ahead.
the situations I've seen, oh, sorry, I think there was a glitch. The situations I've seen are women who they think they're in immediate danger from their missed miscarriage for wanted pregnancies, nothing to do with, that complexity. Wanted pregnancies, heartbreak of missed miscarriage, confusion. They think they're in immediate danger and they want to resolve it immediately, largely because they think they're in danger. And their physician urges or recommends or requires even waiting days or a week or something. And they interpret that as they want to make sure I'm dying before they help
Before they do
me.
something. Yeah.
So to be clear, I'm saying this wasn't the woman opting to do this to give her time to emotionally process. She is not okay with waiting. Why would a physician still recommend that?
Recommend
Um,
waiting.
yep.
Yeah, yeah, absolutely. Well, so one, I think it's really important to point out that, again, I know we're talking about this outside of the context of pro-life laws as well,
Hmm.
but no laws limiting or restricting abortion in any way in this country limit the treatment of a missed miscarriage like this. So
Yep.
I think that's important to understand. But then, so, okay, let's talk about the situation that a physician might recommend waiting a little bit or maybe doing something that isn't resolving the miscarriage immediately. So we talked about if the baby measures 7, 8, 9, 10 weeks, we definitely should see a heartbeat. But if the baby is only measuring 5, 6, even early 6-ish weeks, between 6 and 7 weeks, there is the possibility that there may be a heartbeat, baby may be alive, but we just can't see that yet on ultrasound. And so,
Hmm.
there may be a situation where a woman is having some bleeding. Bleeding is actually very common in early pregnancy. It always needs to be evaluated because we have to make sure it's not an ectopic pregnancy and we have to make sure she's not having a miscarriage. But it is actually very common in early pregnancy, even with a normal, healthy pregnancy. So let's say she comes in, she's having a little bit of bleeding. She's 5 weeks and 6 days. We see that the baby's inside the uterus, but we don't see a heartbeat. Just the fact that she's having bleeding doesn't mean that she is having a miscarriage. And there is the potential that we just can't see that heartbeat quite yet. The heart
Hmm.
is beating, but we just can't see it quite yet. So that's a situation where I would give her good bleeding precautions to say, if you have this amount of bleeding, you definitely need to come back in to be seen. But I would suggest we wait a week and let's do a follow up ultrasound again so we know exactly what's going on. And I can't tell you, Monica, how many times I have had patients in that exact situation that we bring them back a week later, their bleeding has stopped, their baby is perfectly healthy. And so there's no harm in waiting to be sure. I've had other situations where typically we say that early in pregnancy, if the heartbeat is below 100 beats per minute, that could be a sign that maybe that baby's not going to survive. I have seen other physicians, we do an ultrasound, the baby's heart rate is 80 beats per minute. I've seen physicians intervene in that situation and do a DNC and say, oh, this baby's not going to survive anyways. I can't even tell you, again, in that situation, how many times I've had patients come back. I say, there's no need to do anything right now. Let's bring you back in a week. Let's see how baby's doing. And then the baby's totally fine. I've also had situations where you bring them back and the baby has passed away, but then at
Sure.
least you know for sure before you intervene. So,
When I had the situation I just described, even though I know my OB felt clinically very certain just on the first appointment, like she didn't express any uncertainty about it,
mhm,
we decided to wait a week and still do one more just in case. And it wasn't because I was holding on to false hope that there'd be something different. I didn't think there would, but I did want to be able to rest in that assurance that we super double checked
yeah,
before
yeah.
anything else.
Yeah, for
So,
sure, for sure. And there's no harm in doing that. And the patient definitely needs to be counseled well, be watching out for these things. If these things
mhm,
happen, you need to come back sooner. But that's very common. And I would say is actually standard of care. Because again, we want to know what's going on before we do any kind of intervention. And then as you brought up in your situation, there's sort of three different options. Again, this is standard of care. It doesn't have anything to do with abortion laws. Three different options that we can offer women who have now a definitive diagnosis of a miscarriage. So again, if we think that the baby just recently passed away, we can do expectant management, meaning we don't do anything. We give her a week, 2 weeks. I typically won't wait longer than about 2 weeks, but give her 2 weeks or so to see, is she going to pass everything on her own? Another option would be treating with medication. So in my practice, I use misoprostol and also give her some pain medication and nausea medicine. And only do that up to a certain gestational age of pregnancy, and make sure that she's close to the hospital, can get to the hospital if she needs something emergently. And then the third option would be either an early aspiration or a DNC,
right.
depending on how far along the pregnancy is. And that obviously resolves things immediately. It's one of the benefits of having surgical treatment. But the downside is it's a surgery. It could potentially lead to scarring in the uterus if she has multiple DNCs. But with a medication treatment, that may take a few days to fully
Also quite
resolve.
painful
Um,
for some
right,
people. Well,
right,
speaking
yeah,
from the patient perspective, I chose to do a week later do the DNC because how I knew that it's longer and that it's painful and that, there's just a lot of at home bleeding. And I don't blame anyone for wanting to handle it on their own, in their own home and stuff, but I think it's a pretty valid
Oh,
factor.
totally. Totally. And
Yeah.
when I talk to patients about their different options, oftentimes I'll address what you just said.
Sure.
Some people really want to avoid surgery, and I totally understand that. But you
Sure.
should know, if you do this at home, that's why I give pain meds, and your bleeding may be prolonged and it may be so heavy that then you're having to emergently come into the hospital. And so you
Yeah.
need to do that as well.
There's also comfort in knowing kind of when things are going to happen.
Right. I think
Um,
so too.
but I'm all, I totally understand different women have different. I'm also like very pro. Can I schedule my induced labor with an epidural and just, like different
That's
different
right.
things for different
That's,
people. I get
that's
it,
right.
but
That's right. Yeah,
uh
absolutely.
no, but that's really helpful because there are stories, and we're going to talk about this in a second, where the response does seem to be abnormal medical care, but I want to delineate those from standard treatment for ectopic pregnancy and miscarriage, where it's standard to find out there may be an issue and then not immediately go to like an emergency OR or something,
Right.
So,
I would like
um,
to point out too, because I think that there's been some other stories that have come out over the last few years about what sounds like, anyways, again, I don't have these patients' medical records, so I can't say definitively, but at least from what's reported, what sounds like women presenting being told they have a miscarriage and then just sent home and not offered any other options other than, I guess, essentially expectant management. So, not offered medication, not offered surgery, or women presenting multiple times. So, maybe they initially opted for expectant management, but then they come in and they're bleeding and then nothing is being done. That is not normal medical care. Those women should have been offered interventions
right.
in those scenarios. So I wanted to just make that clear as well, that even though, yes, expectant management is one option, again, this is shared decision making with the patient. And if there's something going on that tells us as a physician, expectant management is really not safe, like the amount of bleeding she's having, or maybe some subtle signs of infection, things like that, that is not somebody who should be sent home without any kind of treatment. So,
Well,
so if
and from what
that
you
happens,
described,
that's not normal medical care.
right. And from what you described, there are many situations where maybe expected management would be perfectly safe, and that's just not what she wants to do.
Right.
And that's also a standard consideration. So
Absolutely.
that's very helpful. And that segues perfectly into the next part, where we're going to talk about two specific cases, Emily Waldorf out of Arkansas and Kat Cammack out of Florida. And the reason we're talking about these cases in particular is because there are plenty of what secular pro-life calls the denial of care cases,
Mhm.
stories, where in our opinion, the stories describe something that was not denial of care based on anti-abortion laws. And we've done a ton of work explaining the different things you can look for in these articles, where they're taking a case where someone did not get appropriate medical care. That part is true.
Mhm.
And they lived in a state with an anti-abortion law. That part is also true. But there are a bunch of factors to the story that make it seem implausible that those two things are connected the way that they're saying. Emily Waldorf and Kat Cammack are different, in my opinion, because they're reported saying the same thing you did. We only have what's publicly available, at least for the Emily Waldorf case. I know that you have a little bit more information regarding Kat Cammack, but in both cases, there was strong evidence that the medical teams did explicitly connect the anti-abortion law to their decision making in the treatment they were offering these women, and they were not offering them standard of care, and they were not offering them the treatment that they should have been, especially in Emily Waldorf's case. And so, let's start with that one. I'll just recap briefly. It's September 2024 in Arkansas, and she is 17 weeks pregnant, and she has, you're going to have to help me with the clinical terms, but her baby has descended into her cervix. I believe even one of the baby's feet was outside of her. And she goes to the hospital in Arkansas, and they will not do any interventions. They will not induce labor or anything like that. She's there for several days. Her amniotic fluid, her water breaks, and they still will not intervene. And they pretty explicitly tell her and an attorney they got involved that they are worried that that will trip them up with Arkansas's anti-abortion law. And the attorney that got involved gave them evidence to show that what they should be doing is not only standard medical practice, but as well within the commonly understood exceptions of Arkansas's anti-abortion law. And they said not the doctors, but the hospitals, like risk management or some legal person, said, well, we can't discount the possibility of an overzealous prosecutor. So basically, like, if there's any non-zero possibility that anyone anywhere might disagree with you, we will not intervene. And they ended up having to Emily Waldorf ended up having to say just the right words and language to get released to a hospital in Kansas, a multi-hour ambulance ride in the middle of all of this that she'd been enduring for days. And as soon as she got to Kansas, they were literally waiting for her, and they intervened immediately. And it's a good thing they did, because right after that, she started hemorrhaging and they were able to fix it. And she is safe. Obviously, she lost her baby. But she went through all this. And by the way, just venting at this point, the Arkansas hospital refused to help cover the thousands of dollars for the ambulance ride because they said that they had not agreed that it was medically necessary, and she's the one who wanted to do it. So just like as a cherry on top, that's not important to this episode. I just have a lot of opinions about American medical systems sometimes.
Yeah.
But anyway, that's Emily Waldorf.
Yeah.
And the ProPublica coverage of it was very interesting, because ProPublica themselves have been the source of many of these denial of care stories. And a lot of times their framing is what I said, where it's someone was harmed or even died without proper medical care related to pregnancy in a state that had an anti-abortion law. But nobody involved said that it was because they were worried about the anti-abortion law. And there's other reasons you can see for why malpractice or misunderstanding may have happened. And ProPublica just kind of tries to hand wave it all together. This was not like that. This was very clearly, they specifically said repeatedly. And again, another thing is, this was years after this law has been in place. You would expect a certain amount of whiplash and confusion anytime there's a major legal change. Sure, fine. In the first 6 months, maybe 12 months, if we're being ridiculous. Years later, that's the first thing. And the second thing about ProPublica's coverage of this that was interesting to me is they themselves, ProPublica, they seemed to shift from saying these laws are so confusing, these poor doctors don't know what to do, to saying these doctors are being ridiculous, or this hospital, I should say, the hospital is being ridiculous.
Yeah.
They quoted at least 2 pretty major abortion advocates saying it's willful ignorance to act like you don't know you can intervene here. The attorney that was involved, that was trying to help Emily Waldorf, was a major reproductive rights attorney. And she was saying the Arkansas law allows for these interventions. And that's notable, because a lot of our arguments with the pro-abortion side have been whether the laws allow this or not, and if it's reasonable for people to think the laws allow this or not. And they're saying the laws are super confusing, they don't allow this stuff, and people are confused. And we're saying, I don't know why that would be confusing. Here's all our reasons.
Right.
This is different. Now the abortion advocates are also saying the law clearly allows this, and this is willful ignorance. And I read that and I was like, we're evolving.
Yeah, that's right. That's right.
Anyway, that's the synopsis of Emily Waldorf. What are your thoughts about that situation?
Yeah, well, lots of thoughts. And so I want to kind of break down a few different things. And the first thing I want to start with is one of the things that you said as you were recapping the case, that and this is from the article. It was sort of framed this way in the article, but again, in the interest of good education and accurate information for people, I wanted to point out one thing from this story, in that it framed it as, it was good that she got to Kansas when she did, and but that delay in care that happened was the cause of her hemorrhage. So actually, again, not having her medical records, that actually wasn't the cause of her hemorrhage. That delay in care wasn't the cause of her hemorrhage. So I believe she was 17 weeks along when this all happened. When women deliver babies at really anywhere in the early second trimester, so before about 20, 21 weeks, there is a very high risk actually of retained placenta, regardless. So even if she had gotten immediate induction of labor when she went into the Arkansas hospital, she still would have had a very high risk of a retained placenta. It's one thing I counsel patients on when we know we're going to have a delivery at that stage of pregnancy, is that we're going to give you some medications right after the baby's born to try and encourage delivery of your placenta, but you have a pretty high chance of needing a DNC to get that placenta out. So
Sure.
So I just want to clarify that point that was made by ProPublica, because even if she had been induced immediately, she still would have had a very high chance of having a retained placenta and needing a DNC. So
I read the ProPublica article as suggesting possibly that, but also according to their reporting, when she first presented with these issues, the hospital wanted to discharge her and told her that she might deliver at home. And I forgot to say she worked for this hospital. I feel like there's just
Right.
more and more details that make it,
I know.
but
So,
she advocated to be allowed to stay just in case.
yeah.
And part of that's a little bit of a sharp edge because of what you just said. If she had,
Yeah.
my understanding, if she had delivered outside of a medical setting, same thing with hours-long ambulance ride to Kansas. If she had
Right.
delivered,
Right.
well, I mean, she would have been with,
En route. Right.
emergency technicians and
But
ambulance,
still,
but
but they
still.
can't treat a retained placenta. So yeah. Yeah.
So still in all, I'm glad you clarified that. It's not necessarily that she had a higher chance of hemorrhaging because she had to wait and wait and wait. But I think the Steelman case of their point is this hospital kept trying to just not have her be their problem. And
Right,
it's,
right. No, absolutely. That
yeah,
was one of the other things I was going to point out because we have a lot of detail because she started journaling about what was being told to her and what she was experiencing. And there were so many things that I read in this story that I just thought, what on earth were they doing?
yeah,
Not the patient, the hospital, and the physician,
yeah,
if this is what was said to her, which I have no reason to doubt that,
right.
then what on earth were they saying? First of all, this is not a person you send home. Regardless of what you decide, if you decide expectant management and to try and get the pregnancy as far along as possible, if you decide immediate delivery, you don't send her home for the very reason you just said. First of all, the emotional and mental trauma of delivering this baby at home is huge. You want to know as a patient that you're supported by a medical team when you deliver your baby, but also the risk of a retained placenta and hemorrhage is very high. So you would never in my hospital, I have treated patients in this exact situation, and I've treated both ways, either with labor augmentation if it was obvious they were going to deliver, or expectant management for patients who really wanted to do everything
Still
they
in the hospital.
still in the hospital.
Mm-hmm.
Exactly. Never at
Mm-hmm.
home, never at home. And we can talk if we have time about what that expectant management might it's actually not expectant. You're actually doing some interventions to try and maintain her pregnancy. So they should have never been trying to push her out the door to send her home for the reasons that you and I have both laid out. The other thing is so what happened with her, it sounds like, is she had cervical dilation. So her cervix opened, the bag of waters around the baby, what we call telescoped through the cervix. So it was kind of bulging down into the vagina. And at least at one point per this story, at least one of the baby's legs was down into the bag. At that point, most people would consider that you could say, and you could say legally, and you could say medically, that this is an inevitable loss, inevitable pregnancy loss, inevitable delivery at that point. And so, and as you said, they contacted an attorney who said, under Arkansas law, yes, this would be considered one of those exceptions. They could have augmented labor immediately. From my reading of the Arkansas law and from, this other attorney's reading, I think the real problem here is why is the hospital risk management team getting involved in this case? This is a case that the treatment should be decided based on the reasonable medical judgment of her care team, who is saying that she is at risk for infection when the bag of waters is exposed. That's true. Now, I will push back a little bit on how that absolute risk is framed in this story. So there is an increased risk of infection, which could lead to sepsis if it's not treated and not recognized immediately. And there's even something later in the story where she says her temp is 99.4 and they're still not intervening. Again, that's a point where you're like, okay, temp's starting to go up. We're not messing around here. Okay. It's time to just go ahead and get her delivered. So, that's another area where they should have intervened, but I'm sure they've got their hospital risk management team that it sounds like you know, was delaying them. And the point that you brought up where they say, well, we can't rule out the possibility of an overzealous prosecutor. If that's what our hospital risk management teams are worried about, then why is the hospital even open? I mean, we as
Exactly.
physicians,
You could say
yeah,
that about anything.
anything. We as physicians, especially as OBGYNs, carry the sort of threat of a malpractice suit over us all the time.
Yeah.
But we know if we are providing excellent medical care that is evidence-based, it's based on standard of care, that we can make a defense for ourselves, even if that were to happen.
And Christina, I don't want to get too far afield, but I'd be interested in your perspective speaking as a non-medical person, it reads to me in a lot of these cases that even when they do provide abysmally terrible care, people can't sue them anyway. Emily Waldorf can't sue that hospital. She tried. She can't sue anybody involved. She's suing the state of Arkansas instead related to their anti-abortion law, but it sounds to me like the hospital was well outside normal practices and she still couldn't sue them. Like who are they
Well,
afraid of? It seems like
well,
almost
right.
the
And
opposite problem.
I'm not sure why she can't sue the hospital. Because if it really was the risk management team at the hospital that was keeping the doctors from intervening when they legitimately felt like they had a medical reason to intervene, then to me that should be a lawsuit that could happen. And and I don't think suing the state of Arkansas over their pro-life law is the right avenue for justice for her. Because again, I would make the argument that Arkansas's law actually would have allowed for physicians to intervene in her case in Arkansas without her needing to go to Kansas.
Sure.
And it it breaks my heart that she had to go through what she went through. I mean, this is just an awful situation for any family to be in. I know we're going to talk about in a minute what we do think are some remedies that could help prevent situations like this from happening.
Sure.
Um, the one other point that I wanted to make, and again, I want to be very cautious here to say, again, I don't have her medical records in front of me. I don't know exactly the words that were said to her when her doctors were counseling her. But I also think that this is an important conversation to have because oftentimes when these stories come up, it's sort of framed as, well, the only reasonable medical treatment or medical intervention here would have been immediate induction of labor. And again, I'm not saying that that would have necessarily been the wrong choice. I've been in a situation where we needed to make that, but I also think it's important to point out that there are many situations that present exactly like this, where when we talk to patients about here are different options. Now, we can't guarantee you that we can keep your baby inside until the point where baby can survive outside of you. But there are things that we can do to try and increase the possibility of that happening and without significantly increasing your risk as the patient. So
Right.
I've had patients that presented exactly like this, no signs of infection when they presented, no signs
And
of
the telescoping issue
and
too?
the telescoping
Mhm.
where membranes are in the vagina
Mhm.
where baby those little stinkers are crazy in there sometimes. So, where baby's up inside the uterus, but occasionally we'll stick a foot down into that bag or stick a
Mhm.
hand down into that bag or something like that. But then because they're in there, they're doing fine at the time, they're moving around. Sometimes that leg will come back out. Sometimes that arm will come back out and baby will be fully inside of the uterus. And no signs of labor at the time, where we put the patient in a position called Trendelenburg. So we essentially put the patient on her head to take away gravity from putting pressure, from keeping that bag of
Sure.
waters down in the vagina. And we watch. Sometimes we may give a little medication to relax her uterus a little bit. And in that case, sometimes, again, I'm not saying every time, but sometimes that bag of waters will actually retract a little bit back up into the uterus and not be
But
so
again, that involves some kind of intervention to help her one way or the other, as opposed to
Ex
just saying, "This is
exactly.
terrible,
Just
go
go home,
home."
there's nothing we can do for you. Exactly.
Right.
That is not standard medical care, certainly. And
Yeah.
then in rare cases, but there are cases, sometimes then that patient becomes a candidate for a stitch in their cervix, something called a cerclage that will help hold that baby in. And even sometimes and this isn't me doing this would be a high risk OB doing this, but those membranes can actually be reduced back up into the uterus very, very gently, and then a stitch put in the cervix, and then the baby can make it farther along. So again, I don't know that she would have been a candidate for something like that because
No.
there's not enough information in this piece. But I wanted to point out that the options are not either immediate induction or you go home. There's lots of other things that can be done. And I think it's important to point out that under the Arkansas law, they actually could have done immediate induction for her if they discussed all of the options with her. And that was what she decided to go with.
That is good to know because I very much did think, based on what I read, that it was a no-win situation, and I didn't realize that there could be things, even if it's unlikely, that you could do to try.
Yeah. And even if her water breaks, just actually the day before we're filming this, so on June 30th, a study actually came out in the journal Pregnancy looking at doing interventions in women with pre-viable preterm rupture membranes. So, rupture membranes between 14 and 22 weeks of pregnancy, and actually showed that if we do some of the same interventions that we do after viability, mainly giving what's called latency antibiotics and then keeping her on, reduced activity and monitoring things very closely, that not only did they increase the percentage of babies who made it to the point of viability before they were born, but also increased survival rates for babies. So the other thing that was mentioned in this story is that if her water was broken at 17 weeks, her baby had 0% chance of survival.
Yeah.
That's not true. It's not a
Yeah.
0% chance of survival. So again, I'm not saying that would have been the right option for her, because there's so many things that play into that. But I also believe that patients need to be able to make decisions about their medical care based on accurate information, not based
Yeah, and
on
in
fear
advocacy
and
for
hunger.
access to abortion, we've seen many, many cases where people diminish the odds of survival of lots of
Right,
different situations and the other
right,
options that people could have. And it's not just the women in these stories who are affected by it, it's the thousands of women reading it who may be in situations like this in the future. So it is important to have accurate information. I totally agree. I'd be interested to see that study. That's interesting. But in any case, yes, I think it's important to know there are multiple options and we don't want to lose that frame. I also think there is one other point I wanted to make. I don't think it's a coincidence that the stories we hear of either hospital administrators or medical teams or whoever dramatically overinterpreting what the abortion laws actually say are the same teams that also don't offer very standard medical care that's not impacted by the abortion laws. So, for example, let's say they were right. Let's say they were right, and Arkansas basically said you could never intervene ever when a woman is pregnant unless they are about to die in 5 minutes or something, which is not at all true. But let's say that that was true. Okay. Why would that mean that you discharge her? You could
right,
just let her stay in the hospital
right,
without coming anywhere close to a whiff of possibly even being related to induced abortion. And this is what irritates me about these stories. There's often situations where maybe if we're being ridiculous, we could interpret what they're doing as their fear of the abortion law, some of what they're doing. But there's usually also other things they're doing that are not standard care, that are terrible ideas, that aren't related to the abortion law at all. And I just don't think that's a coincidence. I think that they're not doing their jobs well.
right.
And
Exactly. And
yeah.
and if the law really prevented them, as you said, from doing any kind of intervention until the baby didn't have a heartbeat, but what they really wanted to do was actually give this patient medical care, then again, why wouldn't you keep her in the hospital so that you could monitor the baby's heartbeat, every few hours, so that as soon as there maybe wasn't a heartbeat, then you could do an intervention? Like, none
No
of that
kidding. Well,
sense,
and I can't remember if it was the direct ProPublica article or they linked to things related to lawsuits she's involved in. So I can't remember which source it was. But somewhere they claimed the hospital wouldn't even give her antibiotics. How's that related to avoiding the perception of abortion? Come on.
Right, right. Yeah,
Just okay.
yeah. I mean, there's just any number of things with this. And again, I wanna make it clear that, that my heart goes out to her and what she had to face, and that the other thing that I always think is so awful is when patients in the midst of a really horrible situation have to advocate so hard for themselves because their medical team isn't advocating enough for
Yeah,
them.
your mental and emotional
Um,
energy is already sapped, and now you have to deal with this bureaucracy nonsense.
right,
So
right.
this segues nicely though into one of the other things that was notable about this ProPublica article compared to their other ones is they cited in a favorable tone different methods that pro-life forces have taken to try to put an end to this nonsense. My favorite, I'm just going to touch on briefly, was that Texas has sanctioned some doctors for their ridiculous behavior. And sanctioning to me isn't like amazing, because it feels like a slap on the wrist sometimes. But at least they went out of their way to say, this is your fault and
Right,
you suck,
right.
minimal low bar. But I would like you to talk more about, and ProPublica addressed this specifically in the Waldorf article, Texas as an example of a pro-life state that has gone out of their way to make sure this is totally unambiguous by requiring continuing medical education for all OBs in Texas related to how the abortion laws work. Can you talk more about that program?
Yeah, absolutely. I think it's so important, because as you said earlier, we did see confusion, particularly after a lot of these state laws first went into effect. Thankfully, I mean, point out this story about Miss Waldorf is from 2024.
Hmm.
Thankfully, we're now in 2026. I don't think we're hearing as many of these stories that happened recently. So education is working. That's why I'm saying this, because
Right.
education is working. So Texas, along with several other laws, or several other states like Florida and South Dakota, have mandated education for physicians in their states so that they don't delay necessary care because of fear of what their law does and does not prevent. Outlawed Action has promoted and supported a medical education law in several states. And so Texas's law went into effect that said that physicians need to be educated. But the other really important thing actually about Texas's law, and I think more states need to do this, is not only did they require continuing medical education for physicians, they required continuing legal education for attorneys
Mm,
throughout the state so that
that's more
attorneys
relevant to the
would not.
Waldorf case.
Yeah, exactly. So that
Yeah.
attorneys would not be making the wrong call on what their law does and doesn't prevent. It's important for us to point out not a single physician has been prosecuted in any pro life state because of intervening when a woman needed medical care under that state's abortion laws. So
Right.
it's important for physicians to understand that, for patients to understand that, and for attorneys to understand that as well. And so it's really important that more states, South Dakota has passed a law and put out a great video giving their physicians education about what their pro life law does and does not prevent. And so it's really, really important that if a state is going to enact a law that is going to regulate abortion in some way, that they ensure a good system. For their physicians to receive education. Because the other thing that was actively working against physicians fully understanding these laws were groups like the American College of OBGYNs, ACOG, who put out their Blame the Bans campaign in 2024, the year that this happened to Miss Waldorf in Arkansas, saying that doctors had their hands tied, that they couldn't intervene unless patients were actively dying, which of course is not true. They were spreading misinformation that was actually directly negatively impacting patient care. We at Applog invited them when the Dobbs decision came out. We invited them. We said, look, we may not agree on the issue of abortion, but we should all agree that physicians need to accurately understand their state laws so that they don't delay necessary care. ACOG refused to join with us in that. And so Applog took the lead. We have a continuing medical education video on this topic exactly, featuring a high risk OB and an attorney who's well versed in state abortion laws, who talk about why doctors can intervene, even particularly in a situation like Miss Waldorf's, actually,
Hmm.
and be perfectly well within the bounds of their state law.
I think it's really important that I know Texas does this. I'm not sure about South Dakota, that it's not just that they offer this information, it's that it's required. You have to receive this information, because what can happen is you can have different people on the medical team who may or may not have heard different things about the law. And if you don't have this as a standard part of their education, they won't necessarily be aware that you're offering this
Right,
other
right.
information. So,
Absolutely. And there are methods already in place for that to happen. So there are certain things that are required by different states for your licensure renewal. So that this could be tied to that. The next time you have to renew your license, you have to complete this medical education course before
mhm,
we'll renew your state license. There was even
pretty
one.
organic.
Yeah, there's even one nationwide that we all had to do to renew our DEA licenses about opioid dependence, and that was, that was on a national level. So, so states very definitely can do this, and if they care about women's healthcare, necessary healthcare not being delayed, they really should do that to ensure all of their physicians and their attorneys are well educated. And I know we were going to bring up, we're running close on time here, but I do want to make the point that, Representative Cammack's story recently was sort of splashed in the media again. I think really politicizing her excruciating journey that she went through with a pregnancy loss due to an ectopic pregnancy, where she went to her Florida emergency room not long after their heartbeat law had gone into effect and really had to advocate hard for herself with the physician who was afraid that he or she couldn't intervene because of Florida's law. Now she's a legislator, so she knew that Florida's law specifically exempted ectopic pregnancy, and but it still delayed her care for several hours before she was able to get the care that she needed. And and she has raised a good point of, I knew to do that because I knew my state law well, but what about just sort of a general woman who doesn't know the state law, who maybe a doctor tells her that they can't intervene, that could really delay necessary care and impact her outcome. And so, thankfully, Florida has enacted several measures to ensure that physicians are educated about their law. In fact, they did before Cammack even went to
Yeah.
her
So I just
emergency
want to
room.
emphasize that for a second. The Cammack story is very frustrating to me because Florida passed their heartbeat law May 1st of 2024, or it went into effect May 1st of 2024. On May 2nd, their Agency for Healthcare Administration initiated rulemaking that said a bunch of things, but including, quote, the treatment of an ectopic pregnancy is not an abortion. So Florida, in my view, they anticipated this
Right,
problem, and they said,
right.
listen,
Yeah,
we know there's a lot of confusion and misinformation going around the country. We just put this law into effect yesterday, just to be super duper extra super special clear. Okay, this has nothing to do with treatment of ectopic pregnancy. And yet, a few weeks later, when she goes in, they're not sure. The first question we should be asking ourselves is, how is that possible? How is it possible that you're not sure? They put this big neon sign saying you could treat ectopic pregnancy, and they still say they're not sure. That's the first thing. The second thing I wanted to say is that she said back when it happened and when the story first broke in 2025 that she believes they weren't sure because of fear mongering and purposeful misinformation. And so it's so ironic then that the coverage of her particular case is doing the same thing we were just talking about, where they're trying to say that the law was confusing. And so, there's tons of comments because she is a lawmaker and she's a conservative about how she gets what's coming to her because she voted for this, and you don't want the laws that you pass to apply to you. And it's so ironic because her whole point was like the law very explicitly in like 8th grade reading level terms, they
right.
said exactly that it doesn't apply to ectopic pregnancy treatment. And the fact that physicians are still confused or hospitals are still confused is evidence of something other than the actual text of what lawmakers are saying clearly. And then with no sense of irony, the larger media covers her story like, see, this is because of the law. And you're like, well, it's because of something. It's in the room with us. Okay.
Right.
But yeah, just kills me. And so when it resurged, it was June 21st of this year when I can't pronounce this woman's name, brought the whole case up again. And I was like, you're making her point for her. Cammack said very clearly that people doing what you're doing are the reason doctors are nervous. This is the whole thing.
Yeah.
Anyway, sorry.
Yeah.
Go ahead.
And not just that, but for Representative Cammack, renewed death threats against her and her young family as well, which, is appalling to me. And one of the many reasons why we came out very strongly in support of her yet again, that no one should face that for simply speaking the truth. But it does raise an important point that I have often said, doctors are people too. So that means we are in the culture. We're watching the same news that non-doctors watch. We're looking at social media, we're reading the same news articles, things like that. And so the people that really should be held responsible for these kinds of misunderstandings of the law by physicians or maybe even by hospital attorneys and hospital systems are the media that are perpetuating this misinformation and the medical organizations who have joined in it. They really should be held accountable for this because they are the cause of delays of care. When they, again, even if they disagree with the law, they could be joining with us and saying, we may want this law changed because we want abortion available, but let's be very honest and clear about what the law actually says. And so I think it's really, really important. And it's very frustrating to me, as I know it is to you as well, that as you said before we did this, in the year of our Lord 2026, that people are still misunderstanding this.
Well, so I do want to say
miscarriage is not the same thing as an elective induced abortion,
Well, and I do believe that there are plenty of people on the abortion rights side who, in all sincerity, don't agree with our interpretations of what the law says. They're not just ignoring it, they don't agree with it. But it would still be helpful if then they would look to, and ProPublica kind of did this with the Emily Waldorf article, where they basically said, listen, we asked the sponsor of the law and she said it should allow this intervention. We asked Americans United for Life and they said they agree with the intervention. We asked abortion advocates in other places and they said the law obviously allows it. Like they're starting to show more of a consensus of like, whatever you think, you could interpret any law a bunch of different ways if you really, really wanted to, but we clearly are seeing a consensus. I said when we covered it, I said nobody wants this. Pro-choicers, pro-lifers, doctors, patients, the people making these laws, nobody wants Arkansas to say, oh, you're at 17 weeks with PPROM and we are sending you home. Nobody wants that. So
Exactly.
if we all agree, it should be
Right.
well,
That's
and
right.
we could keep fighting, like you said, we could keep fighting about elective abortion, and we will.
Right.
But
Right.
nobody wants this. This should be easy common ground. And I am feeling slightly less infuriated and slightly more hopeful because of the way ProPublica covered that
Yeah.
case.
Yeah.
Maybe there's. Well, I'm
That's
sure
right.
we'll have plenty to fight about still, but
That's right. That's right. No, I
yeah,
agree with you, Monica. I think it's very encouraging that an outlet that obviously continues, but also in the past to advocate for, open access to abortion is recognizing that actually these laws do allow for interventions in cases like Miss Waldorf's. So let's all, I know both you and I are huge advocates of when we can find common ground, let's find common ground and
absolutely.
let's work from there. And so, let's make, if you're okay with it, let's make our call to action that let's find common ground on this. Let's ensure that every
I'm
physician,
always okay with that.
every attorney in the US understands what anti-abortion laws do and do not prevent. And let's ensure that they get the education they need. And, selfishly, as the head of AppLog, as a plug, we can do that very easily. We have an amazing resource that is structured not just from a pro-life perspective, but just a let's be educated on this issue perspective. So people can go to meded.applog.org and get access to this important education video. And so I would say, if anyone is watching this who knows an attorney or knows a physician, direct them to this resource, please, because it is so, so important that patient care not ever be delayed because of an attorney or a physician's misunderstanding of a state abortion law.
Yep, 100%.
All right. Well, Monica, thank you so much. I know we're up on time. You and I could just continue to talk for hours, I think. And we were doing these. That's right. We were doing these pretty regularly before. And so I think we're going to revive this and sort of do these reverse interviews maybe once a quarter or something like that. So Monica, thank you so much for joining us on today's episode of Observations.
Thank you for having me. It was very informative.
Absolutely. And thank you to all of our viewers and listeners for joining us for Observations. We'll see you next week.
We hope that you enjoyed today's episode of Observations and that it broadened your perspective on women's health and how we can care for both patients, mother, and preborn child. If you like this episode, make sure to give us a 5-star review where you can find your podcasts. Make sure that you like this on YouTube and subscribe to our channel for more episodes coming up. And if you have any suggestions on any topics that we should cover or guests that we should have on, make sure that you email us at media@applog.org. Again, thank you for joining us for today's observation, and we'll see you in our next episode.